Anna Thompson, um, who, who hopefully is going to be sharing her slides.
Yes.
Lana, are you?
I'm just going to switch over to slide sharing mode. So if I could just get a verbal confirmation when you're able to see them, that would
Okay.
be great. Just bear with me. Oh, and then I'm just gonna start from the beginning. How's that? Oops.
Yep, that looks great. Excellent. Thank you very much.
Okay, great. So my name's Lana. I'm a speech therapist and a lactation consultant, and I work in acute pediatrics and neonatology in London. And my talk will be about my experience as the lead author of the EDAR policy for our hospital and community team at St. George's in London. So we'll talk through the sort of inception of the policy, drawing on a lot of case examples that people have shared, and then I'll share some specifics from it as well. So as I said, I work in St. George's, which is in Southwest London. And to give you a little context about our need to develop an EDAR pathway, we're a large tertiary pediatric children's hospital with a PICU and a surgical NICU. We're a major trauma center, and we've got a really big cohort of polytrauma patients, respiratory patients, patients with neurotrauma and neurosurgery, as well as lots of ENT and complex airway patients. So that's what we manage on an inpatient basis. An outpatient, we manage a VF and joint airway clinic. And that's the extent of our outpatient services, unfortunately. Patients are discharged from us to the care of their local community provider. So we don't have any outpatient clinics other than VF and joint airway. And our EDAR pathway was developed with our team, so the inpatient speech and language therapy team, with input from respiratory consultants and nurses, community speech therapists, pediatricians, and with parent feedback from previous EDAR cases, both in the acute setting and in the community setting. Okay, so we've had a lot of great talks this afternoon about EDAR and framing, if you will, the problem of EDAR, or the problem as it may present itself. So the issue that we may find ourselves in as pediatric speech therapists is that there are a cohort of pediatric patients that have dysphagia for whom diet modification or adaptation didn't result in decreased risk of airway compromise, so aspiration or penetration, when assessed objectively, so for example, through a VF. Diet modifications were tried, but they either didn't result in improved respiratory health or any other appreciable benefit, or diet modifications were not feasible. So the child was persistently refusing, maybe becoming dehydrated or constipated, social mealtime participation and quality of life were limited, and there was significant stress on the child or family. So where do we go from there? So to recap, we're talking about the children for whom an unrestricted diet is unsafe. Diet modifications either aren't effective or have been tried and A, didn't work, or B, weren't accepted. And so now we're at the point as speech therapists where we're wondering to ourselves, what other options do we have? Is there anything we can recommend other than a feeding tube from these patients? Should we consider discharging them from our service if we're not providing any therapeutic intervention? Do we have a role in these cases? So these are kind of all of the things that were ruminating in our minds, and I know the minds of many other speech therapists in the background when we were developing this policy. So I'll touch as well on some common themes of struggles shared with us by local speech therapists from all over the country. As a tertiary center in the capital, we often get telephone calls for consults and questions about case management and complex case discussion. Again, a lot of these discussions prompted this EDAR policy. So I'll share some of them with you, and then hopefully we can chat at the end and people can share if they can relate to any of these. So a really common story is thickener has been advised based on a VF that was completed years ago. The thickener wasn't accepted, and the patient's now been identified as non-compliant with the recommended diet and classified as feeding at risk, with no plan to re-refer to local SLT for VF, perhaps because they won't accept thickener anyway, or perhaps, as some people have touched on this afternoon, there's limitations to their ability to access a VF service to refer back to, certainly in a timely way. But a case where family may feel that swallow physiology could have changed and they want a repeat VF. So that's a really tricky position to be in. Another one is the child's been diagnosed with dysphagia based on observational feeding assessment alone and classed as risk feeding or EDAR with no plan to refer for either VF or FEES. So the case where a child's never had an objective swallow assessment. Another really common theme was children with chronic health conditions that are on an exclusive oral diet, and discussions around risk-benefit of oral versus non-oral means of providing nutrition haven't been completed with a parent. So these might be, for example, our patients who are school age with cerebral palsy involving all 4 limbs in specialist seating systems who have always been an oral feeder. And you might find yourself in a position where you now inherit this case and the patient's been exclusively orally feeding since birth, but you don't feel it's safe based on your assessment. But no one else seems to have flagged it so far. So where do we go from there? So for us, the first step was really taking a step back and thinking about what we know for sure based on the research. George touched on a lot of these points earlier, so I'll keep my points brief, but in summary, the relationship between aspiration and respiratory illness is non-linear. This is a really common misconception, as often both ourselves as speech therapists and our medical colleagues can erroneously assume a cause and effect relationship between aspiration and adverse respiratory health. We know from research that that's not the case. Particularly in children, aspiration is intermittent, variable, and often silent. And the consequences of that aspiration depend on the volume of aspirated material, the frequency with which the child aspirates, the type of material they've aspirated, and the child's underlying physiology. Additionally, and this is a really tricky sticking point, but we know that observations of non-specific symptoms, such as cough, throat clear, or perceptual changes to voice, do not equate identification of aspiration. They certainly may give us a clue or a clinical suspicion that perhaps something has gone down the wrong way, but they do not equate with identification of aspiration. And another really difficult part, because I know that this is such a logistical challenge for so many speech therapists all across the UK, is that we know from the research that only an instrumental swallow assessment, so a video fluoroscopy or a FEES, can objectively assess swallow physiology. It's not to say there's not a huge place and role for observational feeding assessment, but we're in a really unique challenge in the UK in terms of pediatric dysphagia management, where you might find yourself as a community provider who has very limited or perhaps even no access to referring for an instrumental assessment to get some more information about your patient. We also know for sure that modifying a patient's diet may or may not help to make their swallow safer and reduce the risk of aspiration. Again, this is dependent on the child's specific underlying swallow physiology and the dysphagia etiology, which you need an instrumental assessment to identify. And we know that poor oral health is directly associated with respiratory illness in patients with dysphagia. Okay, so there's so many unknowns when it comes to pediatric dysphagia, but there are a few things that we know for sure. So based on that, we tried our best to develop a helpful policy or guideline. But what we found was tricky is that a guideline assumes that if we provide people with the same information, they'll make the same decision. But in reality, different people provided with the same information will make different choices. So we know that decision-making is shaped by values, culture, religion, family circumstances, prior experiences, and what matters most to the family and to that child. And a family may weigh quality of life over risk reduction, and that's a legitimate autonomous choice when appropriately risk assessed. We also know that families from different cultural backgrounds may have different frameworks for understanding risk, illness, and the meaning of food or oral nourishment. And that a family caring for a child with a life-limiting condition may be balancing multiple competing priorities that we really can't fully appreciate. And this is why we concluded that guidelines really can't replace individualized and co-produced risk planning. A guideline tells us what to consider, but it can't tell us what this family should decide or what should happen in this case for this child. There's some interesting citations here. One I'd like to just draw everyone's attention to, if you're interested in this kind of discussion, is this example of a case study that essentially concluded legally that patients have the right to make decisions based on their own values, not clinician judgment of acceptable risk. So, of course, it slightly changes, and I know this is George's area of expertise, but when we're talking about a parent making a decision by proxy for a child, but something to keep in mind. Okay, so with that, I'm going to stop sharing my slides and I'm going to start sharing the policy document that we've made to sort of help us with navigating this really sort of complex and multifaceted process. So I'm just could I just get a verbal confirmation that you can see this document from someone?
Yep, we can see it. Thank you.
Cool, amazing. Okay, so like so many of you, pardon me, we found ourselves in a position where we were constantly getting these cases and really struggling to identify how we could add meaningful value to these cases, how we could structure our support in a way where clinicians felt supported and not feeling sort of that anxiety of like you're making this decision on your own or you are the spearheader of this decision. And we felt that, again, co-production with the medical team, but also with the family would be absolutely essential. And like I think it was the earlier presenter had cited, we noticed that while we felt we were effectively managing EDAR cases on a case-to-case basis, it was extremely time and resource intensive to do so. So that's not at all to say that this has suddenly made it a one-stop quick shop at all, but I do think it's made things a lot more A, consistent, and B, efficient. So I'm just going to fly through parts of this document, and then we can go to a sample of an EDAR plan, and we'll have a chat about it. Okay, so the pathway. So essentially within our pathway, we have the status and purpose of the document. So this is now our trust's official policy for all neonatal and pediatric patients who are eating and drinking with acknowledged risk. And the rule throughout the document is to define the documentation standards for patients who eat and drink with acknowledged risk, and also to define the role of all MDT members and to ensure that families can provide informed consent. And also, and very importantly, to make sure that the child's voice, including their preferences and opinions, are reflected. Okay, so we've defined it objectively in the policy as the EDAR pathway involving an individual continuing to eat or drink orally without therapeutic adaptations to reduce the risk of dysphagia. We give some examples of what those adaptations might be. So the classic ones we're all familiar with, right? Maybe adding some thickener to fluids, maybe restricting the type of solid foods that the patient can have in terms of texture, volume, or frequency. Using different flow rates if we're working with infants who are bottle feeding, maybe trying different drinking vessels or equipment, putting positioning or pacing in place, and then also using non-oral feeding means. So this might be, for example, using a feeding tube for all of the patient's nutrition and hydration. Partial might be state dependent, or it might be with the provision of oral tasters. Okay, so this is an interesting aspect, I think, of our policy that has been really useful for us to sort of consider as an MDT. And that is this family decision making in the presence or absence of an instrumental assessment. So when I'm saying instrumental, I'm referring to a VF or a FEES. And I think the really tricky thing is, given the difficulty with access to these services in the UK, we can in no way dictate or, implement a guideline that states that every single patient must have an objective assessment before they can be on an EDAR plan, because by nature, as I mentioned earlier, some therapists are experiencing several month wait lists referring their patients for these assessments. Some can't refer at all due to staffing shortages, service closures, etc. So what we wanted to think about, though, from our perspective as a tertiary center in London, where we do have regular access to both FEES and VF, the differences between how we might implement these plans in the case where we anticipate that a child might be aspirating based on their clinical history and their bedside or observational assessment versus how we implement an EDAR plan when we've had an objective assessment. We know for sure if aspiration penetration is occurring, and we know the mechanism through which that's occurring. And we also know whether or not other modifications were effective. So if I go down to the roles and responsibilities, I think that this has been a really helpful bit for us as a service, because a real sticking point previously and challenge had been identifying the role of all MDT members as it pertains to EDAR, because previously the role and responsibility of managing EDAR patients pretty much exclusively fell on the speech therapist in terms of initiating the plan, organizing MDT discussions, communicating risk to the family, and it became an extremely time-intensive, but also, I think, quite psychologically burdensome and anxiety-provoking affair. So we've clearly defined the roles here. So the role of the child, parent, caregiver, and speech therapist, as well as additional professionals to consider, and as always, the child's physician. So one thing I'll touch on briefly is just the role of the speech therapist as it relates to EDAR in terms of how we've defined that. So from our perspective, the role of the speech therapist is to assess the child's swallow physiology, provide information regarding the nature of the child's dysphagia, and provide information regarding dysphagia management strategies that could be possible for that child. We give some examples of those here. The SLT's role is also to liaise with the child's doctor and other professionals as appropriate to facilitate EDAR discussions and the development of an EDAR plan. We highlight below the necessity for a medical doctor's opinion when considering EDAR for a child. And this is really critical because only a doctor who's familiar with that child can specifically assess and advise as to what the specific health risks associated with EDAR are for that child, as well as the severity of those risks. So this is really important. And we say that in instances where the child is under the care of a specialist doctor whose specialism is relevant to the child's EDAR, so for example, a neurologist, respiratory consultant, ENT, those doctors should be directly involved in EDAR planning. If they've been seen by another specialty that might not have a role in EDAR planning, for example, orthopedic surgery, then they don't necessarily need to be included. Okay, so in summary, a lot of words here, but the EDAR plan needs to involve a comprehensive assessment of the potential risks and benefits associated with both managing and not managing the swallowing or feeding condition, with consideration to factors such as the child's overall health, participation, nutritional engagement, educational engagement, and hydration. So, for example, maintaining oral intake despite many known risks may enhance social participation during meal times, which could really improve a child's quality of life, right? This is not news to us. This is probably the number one reason cited by families for wanting to continue to EDAR. However, if in a case where, let's say, we're thinking about chronic aspiration versus recurrent acute choking episodes, we might need to pivot our posture in terms of looking at how severe those risks are, and how we might be willing to accept those risks in terms of frequency. So I think this is a really big sticking point. This is something that several others have also talked about, excuse me. But the idea that not all risks are created equal, right? So it only takes, unfortunately, one acute choking event to pose a hazard to someone's life. Whereas if we're looking at chronic aspiration, that might be calculated a little bit differently. Okay, so we then go on to outline the risks of EDAR. Okay, so including, as I mentioned, risks of aspiration, choking, nutritional deficits. Given that there's no empirical evidence for the use of cooled, boiled, or sterile water in pediatric patients with thin fluid aspiration, we just make a comment about that here. I think that's a strategy that sometimes is thought of as a risk mitigation strategy for patients with dysphagia, pediatric patients specifically with thin fluid aspiration, but there's no empirical evidence to support the use of that. So we just, again, would never say that someone can't give that a try, but be transparent about the presence or absence of supporting evidence. So in the interest of time, what I'm going to do now, I'm just going to quickly talk through basically our process of initiating the plan. And then I want to show everybody what the actual plans that we give our patients look like. Okay, so in brevity, so step one, so you've got a patient, you believe that they're going to need an EDAR plan, right? There's no other way that you could see that this patient's dysphagia is likely to be managed. So again, step one is going to be eating and drinking assessment by a dysphagia competent speech therapist. Step two would be an onward referral for an instrumental swallow study, if clinically indicated, or indeed if feasible and available, right? Step three, if it's not clear how the patient's eating and drinking could be safely managed in the interim. So let's say, for example, you are someone who is fortunate enough to have a local VF service in your area that you could refer this child to get some more objective information to inform the EDAR plan. But let's say there's a 3 to 6 month wait list. Then in that instance, the local speech therapist would discuss the options about managing the child's dysphagia in the meantime with the medical team and parents. So you're almost creating that mini contingency plan. And we recommend that for all of our patients if the local wait list is going to be longer than 4 weeks. The next step would be to get your outcome of your instrumental assessment, so your FEES or VF outcome, and have a look through the result, discussing with parents the sort of etiology of the dysphagia, the physiology seen, any limitations on the day, and any strategies that were trialed that were either successful or not successful. Okay, and then moving down, pardon me, thinking about what we want to do from here. So sometimes, as we all know, we'll have children who come for VF. A strategy might be identified as objectively improving swallow safety, but the family might not want to take that strategy forward. So in that case, or in the case of an instrumental assessment finds that nothing really helps, we then move on to an EDAR plan. And I'm going to show you what that looks like. In essence, there'll be an MDT. If the parent speaks a language other than English, this is a real sticking point for us that we found has made life a lot easier, but has also helped with communication breakdowns. So if a parent is a non-native English speaker and a non-fluent English speaker, so if there's any indication at all that that parent is having any level of difficulty understanding verbally presented information in English, we use a professional translator for these discussions. And the ID information of that professional translator is documented on the EDAR plan and within the patient's medical record. And this is because upon case reflection, we've had several cases for whom a patient's been EDAR, and it turns out that the parent didn't feel that they fully understood the risks and benefits to that EDAR plan because, for example, they had informal translation through a family member, which was not accurately completed, or they politely declined translation, not sort of knowing that they were missing information there. And as George had touched on, in some cases, the medical team, so our physician colleagues, may feel that EDAR is not appropriate for that child based on the extent of the risks identified. And in these instances, we are not proceeding to an EDAR, right? So it's not as simple as, okay, perhaps family preference for case management deviates from what we would recommend. Okay, go to EDAR. We need to have sign off from a physician that is comfortable that the risks are proportional and appropriate. And in the instance where they're not, we have an MDT meeting with the medical team, speech therapist, and in some cases, local safeguarding for more advice. Okay, so what we will do, these are just some logistical bits. With our next few minutes, I'm just going to fly through a sample plan. So this is a plan that's created by the speech therapist with input from MDT members. And it's always in this template, and it goes on to the patient's medical record at the hospital, so everyone can see that, and that includes the community providers. We also send a copy to the GP, and we provide the parents with a copy of this, and school as well. So certainly if the school services are separate from the community health provider services, we'd be giving this to school as well. So the purpose, so clearly outlining, explaining risks and benefits of your child continuing to eat and drink with acknowledged risk. So this is a fictitious child here, obviously, living on one Blueberry Lane. So we summarize for the parents who are the professionals involved, who are the stakeholders that have helped develop this plan. We talk about a diagnostic summary, right? So this might be from either your clinical assessment or an instrumental assessment. But what is the formal diagnostic summary for this child? So usually looking along the lines of oropharyngeal dysphagia characterized by XYZ clinical features. We then provide a plain English summary. So again, thinking about accessibility of information, and our general guidance with this is we try to keep the summary simple enough that your average 10-year-old would be able to understand it. So here we've rephrased this as, when Freddie's drinking thin fluids like water, juice, and milk, some of the fluids going down the wrong way into his airway below his vocal cords, and he isn't clearing that. So we summarize for the parent, okay, what are the assessments that your child's had that have led us to this conclusion that they have a swallowing difficulty, and that swallowing might be impacting, their swallowing difficulty might be impacting their health. Okay, so here, this is our real bread and butter. I think this is what's really changed the game for us. The dysphagia management options. And with this, we will have a preliminary meeting with the parent where we're talking through the risks and benefits, okay? So option 1, so for little Freddie, option 1 for him is going to be to thicken all fluids to IDSI 2, avoiding thinner fluids. We provide a rationale, benefits, and risks. Option 2, consume thin fluids despite known risk of aspiration. Again, rationale, benefits, risks. And then option 3. So we might put everything in here that we might consider. These aren't necessarily what we're going to do with the patient, but our primary case management options. In the case of this patient, option 3 might be a feeding tube, and we're clearly explaining to the MDT and parent why perhaps that's a theoretical option, but it's not appropriate at this point in time. Conscious of the time, we highlight the risks associated with aspiration and choking, as well as nutritional deficits. And based on the risks and benefits outlined above, the recommendation, so the medical team recommendation would be here. The preferred case management of the parent is here. And then what we like to think about is a perspective of risk mitigation and harm reduction. So can any steps be taken to potentially reduce the risks associated with the above? For this patient, it's just oral hygiene. And last but not least, we've got a little consent form. We transparently disclose to the parent whether safeguarding has been consulted or will be consulted in the development of the plan. And we put a clear plan for reviewing. So That's our process. And it's been a really positive one for us. I think that with EDAR, there's no 100% perfect way to get it right, but I think certainly it's improved the confidence and the experience of our staff managing these cases to have a uniform framework that allows for consistency and also thoroughness. Thank you.
Thank you so much, Lana. That was so interesting. We don't have any. Oh, actually, we've just had a question, which is the one I was about to ask, which I suspect most people on this are probably wanting to ask is, are you happy to share that document? Because I think
Yes,
most of
I'd
us
be
across
very,
the
very
country are
happy
just
to.
going, wow.
Oh, thanks. Extremely flattering. We're very happy to share it. I think because it is now an official trust policy, I probably just have to get an okay from
Mhm.
someone a bit more important than me to distribute it externally, but I will certainly look into that and then circulate it if I'm able. Yeah.
That would be brilliant. Thank you very much. Because, yeah, that looks like a very comprehensive document that you've clearly spent a lot of time and effort on. So, yeah, well done. Thank you very much. Well, everybody, thank you very much to all of our speakers for this afternoon. You've all been amazing. Thank you so much for putting those presentations together to share with us all your work. And sorry again for all of those technical glitches that we had at the beginning, but we managed to get through everything in the end. Thank you so much. In the chat, I've just put a little link to a feedback form. I'm going to pop up a QR code as well. We would be really grateful if you would be happy to give us some feedback on this. As a CEN, we've been going for probably about a year, I think, ish now, but most of the other meetings have been more adult focused. So it's been brilliant to have a pediatric focus this afternoon and get us all together so we can all kind of learn from each other. So any feedback that you can give us, we would be very grateful to receive. Thank you. I am currently looking for this QR code. There we go. Hopefully that will share. Hopefully you can all see that. But thank you again to all of our speakers for all of your time, and thank you to all of you for coming up and sharing it. I know it can be hard to prioritise time for CPD, but hopefully it's been worthwhile. Thank you very much to everybody.